Thank you. Good morning. It's truly a pleasure to be here. This is thankfully my fourth visit to Singapore, and every time I come here, I see just increasing development of what's going on at Duke and US, what's going on in the Lien Center. It's been very exciting to be a part of this and to be able to observe it and to see what we can be doing together in the future. So I was asked this morning to speak about palliative care for non-cancer in the non-cancer setting, and I think that's important because that really is, in many ways, much of the cutting edge of what is happening in palliative care. Before I go on, I just want to acknowledge that I'm going to be presenting some findings of our own research and some projects that we're doing, and I want to acknowledge the team that is a part of this back at Duke in Durham, North Carolina. And I do this partly because it's important to acknowledge those who have helped you move any kind of a project, but also to remind us all that palliative care, not only in the clinical setting, but in the research setting, is an interdisciplinary affair. And if you could look down this list of people who work in our projects, it includes physicians and PhDs and nurses and a PharmD and statisticians, and those PhDs are in fields from social psychology to sociology to epidemiology and so forth. So just to acknowledge that piece. I have the benefit of being the first speaker at this conference, and so therefore I can get away with introducing the concept of palliative care and what actually is it. The definition of palliative care has actually been a source of quite a bit of discussion, at least in the US and perhaps here as well, but it is directly relevant to what I'm going to talk about today. So palliative care, according to the newest definition, is specialized medical care for people with serious illness, and it focuses on providing patients with relief from the symptoms, pain, and stress of serious illness, whatever the diagnosis. And that's the part that I want to emphasize here. And it's appropriate at any stage of a serious illness and can be provided together with curative treatment. So the question then is, who actually receives palliative care? Well, it's a little bit of a hard question to answer. There's good data, and my data, I'll be honest, is all from the United States. We have good data on who receives hospice care, so that's the first number I'm going to put up here. And the United States percentage of hospice admissions by diagnosis show that cancer is almost 36% of those, heart disease, including heart failure, is about 14%, debility, unspecified, dementia at 13% each, and then lung disease. But the numbers to the right show what the percentages are of the population that die from that particular diagnosis. So what you see immediately is that cancer is overrepresented in hospice, and heart disease, and specifically heart failure, is way, way underrepresented in hospice. So I then tried to look at what about palliative care outside of the hospice setting? So for example, inpatient palliative care. And there is not great data, actually. Professor Sean Morrison is here, and perhaps I don't know if he has any data that's better nationally on this. I just went and looked at our own personal health system and looked at our own hospital and our palliative care consults by diagnosis. And as you can see, this is just from last year, cancer continues to be about 40% of our inpatient consultations, and heart disease, even though we have a good relationship with the heart failure folks, is a much smaller number. So this, and I think when I've talked to people at other institutions, it's the same, and in fact, some of them are even more skewed toward cancer than ours. So once again, I get to throw up a slide that many of you have probably seen, but just to make a point. So the traditional hospice model is that what happens is that there is some sort of life-prolonging curative treatment being used for a period of time until there's a decision made to stop that, and then at which point one enters into hospice care, in this case synonymous with palliative care, and then death. And much of this is driven, of course, in the United States, by the Medicare hospice benefit. So this is the traditional model. Well, why did this develop? It developed because of what the cancer trajectory looks like. And not to say that early palliative care is not appropriate in cancer, because we now know that it most definitely is. And yet, this trajectory does seem to lend itself to that kind of a hospice traditional model, right? And this is obviously schematized, and it's not perfect, and there are different malignancies that behave in different ways, and I'm aware of all of this. But the general idea is that when you have cancer, you function at a fairly high level. Oftentimes, you may have a lot of side effects from your disease, but you're functioning at a fairly high level until a point at which everything gets much worse, and then you rapidly tailor off, which is the point at which hospice tends to be involved. So this is a schematic that many of you have seen that's built out of the work of June Lunny and Joanne Lin and others that shows that chronic illness trajectories actually look very different from the classic cancer trajectory. So if the cancer trajectory would be the one on the top, and is there a pointer by any chance? If you don't have one, that's fine. I'll just keep talking. So at the very top there, that trajectory, as you can see, is the one that I showed before. The second level there is what most heart failure, lung failure, and other organ failure diseases look like, which is that you move along at a particular place of function, have exacerbations, you dip down, you do worse, and, does that work? That's all right. You may have an exacerbation, maybe hospitalized. Eventually, you kind of get back your functioning, maybe a little worse than you were to begin with. Move along, maybe have another exacerbation, then come back up. And then at some point, what happens is one of those exacerbations just doesn't get better. And that's when you end up dying. This is a very different sort of trajectory, and it is one that, as you can imagine, makes no sense with the traditional model for hospice care where one suddenly stops curative care treatment at one point and then goes on. The bottom one I'm not going to talk about a lot here, but this is the frailty and dementia paradigm in which there's sort of the function is much, much lower, kind of dribbles along for a while and eventually leads to sort of more of a slow and death. Now, so here are alternative models of palliative care. So the first one's the one I showed before. The second one is the one that is most trumped up these days in palliative care discussions and in literature, and you see this all the time. And this is the model where, in fact, palliative care starts from diagnosis at a much lower level, but that there might be some involvement with somebody who's been diagnosed with cancer, has been diagnosed with heart disease, has been diagnosed with COPD. Maybe they'll have a little bit of interaction, maybe have some discussions, whatever, and then the palliative care interventions increase over time as the disease progresses and as the person gets sicker and becomes more appropriate. And at some point, palliative care is most of the care that a patient is receiving, if not all of it, and may even be hospice care. And then, of course, there's death, and that black line at the end is post-death bereavement care. The third graph here, C, is one that I think actually offers a more realistic look into what care is going to look like, particularly for patients with heart failure. Because as you see, you have active care and you have palliative care increasing at various times. It's there from the beginning. Actually, they're at a higher level right at the beginning. But active care never completely goes away. And I'm going to show you why in the case of heart failure this is really the case. But you can just imagine if you have a very high-tech device in you, if you have a left ventricular assist device, if you have a implantable cardioverter, you are getting active care all the way right up to death. And so we need to sort of think about that and change these graphs a little bit. So what are some of the consequences of palliative care having developed primarily for cancer initially? Well, the first is the worst in the US, which is that we have this hospice benefit, which is limited to a 6-month prognosis, which is something that's much harder to work with in the organ failure setting. Second of all, decision-making is generally more simplified. I realize that in cancer it's getting more complicated, particularly with targeted therapies, very expensive targeted therapies, non-classic chemotherapies. Yet still there is kind of this on-again, off-again about chemotherapy and other cancer treatments that makes it simple. Symptom control, this is a bit of a stereotype here, of course, but to a certain extent for many years was just more opioid. And it's a lot more complex than that, and we know that even in the cancer setting it's a lot more complex, but certainly when we get to organ failure, we're talking about treatments for those organ failures that become complicated. And low tech has generally been pushed as the desired choice. You know, the hospice philosophy is one that really encourages low tech for the benefit of the patient as a philosophy of care, and yet that may not be the way to achieve the best quality of life and the best relief of suffering for some of the patients that we're talking about with organ failure. And this also goes for home as being the usual place of care. This, by the way, I have some feelings about, because people, on one hand, surveys will say that most people would prefer to die at home if possible, and I'm not sure if that necessarily applies to the Singaporean setting, where I know, for example, in the Chinese community, that's not always the case. But in the US, I can say that, you know, if you ask a survey, people will say the overwhelming majority of Americans will say they prefer to die at home. And yet, if you ask them to rank order how important it is to die at home, the rank ordering compared to other things like getting their needs met, getting symptom control, getting pain control, being with friends, it's much lower of a priority. So they would like to die at home, but only if their needs are met at home. And with some of these organ failure issues, meeting the needs at home may not always be that simple. So, as I've been hinting at here, in heart failure, much more is involved. And, you know, there's this, right? So we have all these patients who are living with implantable defibrillators under their skins, which first, and in many cases, by the way, these are also, in heart failure, they're now used by synchronous pacing as well, which is another advanced technology. And, you know, this is, first of all, it's an expensive device. You know, it's $30,000 to $50,000 worth of device setting them, but it also is something that won't let them die unless we turn it off. Or when they finally die, it'll continue to shock them, right? So these are the kinds of things we have to think about. And how do we manage a defibrillator in a patient when they're approaching their death? There's a wonderful trial going on right now that Professor Morrison's very involved with, and I'm a consultant on the lead investigator is Nate Goldstein at Mount Sinai, looking at exactly this question, which is critically, critically important. And if we thought that the defibrillators were complicated, these are even more, okay? And, you know, this is a left ventricular assist device, to those who haven't seen one. And originally, these were intended to be bridge devices to help people get to transplant. Oh, by the way, in transplant, I don't even have a slide for it, is a whole other issue, because transplant takes a person who is chronically and terminally ill and suddenly changes everything overnight if it works, right? So now we truly have the ability to kind of miraculously take people off the trajectory in a very, very different way. And how do you deal with that? Because, you know, it may or may not happen to the exact same individual, right? So these were initially meant to be bridge devices for people who had severe heart failure to get them to their transplant. Well, now they're being implanted as destination devices. It's called DT, destination therapy, with VADs, right? And you walk around and you've got your heart pumping for you in a little bag sitting around a harness around your, and these are getting better and better and better. But what does that mean? If we're now replacing the heart, but yet the mortality rate is still very high even with people with destination therapy, how does that fit into a palliative care model? These people have a lot of symptoms. They've got a lot of issues. Living with a VAD is a tremendously difficult thing to do. And you have the specter of death on you all the time. So how do we do that? And of course we have this, which is that no matter what, the patients with these chronic organ system problems are on a lot of medications. And lots of different medications that interact in lots of different ways that do actually affect their symptom management, but also are about longevity and are also about keeping them alive. So a few differences, I'm just going to throw out a few specific differences that happen with palliative care for cancer and congestive heart failure. In the area, for example, of dyspnea, what about the role of oxygen? You know, traditionally in cancer, oxygen therapy has been sort of looked down upon. because most of those patients are not hypoxic. It turns out you can probably give them a fan blowing on them or just having some air. It probably does about as much as the oxygen does. But the heart failure, is it any different? Turns out actually it probably isn't. It probably only is beneficial for those patients who are hypoxic. And yet there are physiologic reasons why you can imagine that that might be something you would think about. What about when we're treating depression? So depression and heart failure go hand in hand. Very high rates of depression among patients with heart failure. Traditionally treated with SSRIs and other drugs like that. And yet in cancer, and particularly in very terminal cancer, we often use psychostimulants. Well, how do you feel about psychostimulants in a patient that has heart failure? Is this going to be a problem? The answer, by the way, is that those drugs, I'm talking about drugs like methylphenidate, are probably not such a problem in this population, but we don't have very much data to show that, and we need to know much more about that if we're going to be treating them. Because I can tell you the cardiologists freak out when we suggest using methylphenidate in these patients. What about fatigue? Well, maybe the answer to fatigue is inotropes, home inotropes, right? But we're talking about a whole different level of care than we normally think about when we think about palliative care. What about pain? The pain may be ischemia. So once again, a different model for how we think about this. It's not just throw morphine at it because this is bone pain. And advanced care planning. How do we deal with these very different notions of uncertainty, as well as rescue therapies that I've just been describing? So what I want to do now is talk a little bit about some of our research that's tried to look at how different these diseases really are. So I've mentioned where treatment-wise and so forth there might be some differences, but when we think about the patients themselves, how different are they? So I want to just do a little exercise really quickly. One of these patients has cancer, one has chronic obstructive pulmonary disease, and one of these patients has CHF. So guess the patient, okay? So patient upper left-hand corner, how many think he has cancer? How many think he has CHF? How many think he has COPD? Okay, more. Okay, so we think COPD. One in the middle. Cancer. CHF. Hands go up. COPD. Okay, last one. Cancer. Everybody thinks he has cancer. CHF, COPD. Okay, you're all completely wrong. One in the upper left has cancer, the one in the middle has COPD, and the one on the far right is George Carlin, who had CHF. Oh, thank you. Excellent. So the point is, we look at these people, we cannot tell. Here's a study by Dave Beckelman where he looked at 60 heart failure patients and 30 patients with lung and pancreatic cancer. He found that the patients were very similar in their symptom scores, using the MSAS, their depression scores, using the geriatric depression survey, their spiritual well-being using the FACIT-SP, and in fact, he found that the patients with advanced heart failure had worse scores on all these measures than the cancer patients. When we think about how people suffer from these illnesses, it turns out it's possibly maybe the patients without cancer that are suffering more. We did a study called Pathways. This was a National Institute of Health funded study where we followed 210 patients for actually up to 6 years each. 70 patients with stage 4 malignancies, one of these 4 diseases, 70 that had class 3 and 4 heart failure who had been hospitalized in the last year, 70 who had COPD with hypercapnia and had a recent ED visit. We did monthly interviews by phone. We did quarterly interviews at home. We measured a lot of things. I'm not going to talk, because of limited time, all about this study. But the bottom line was we were looking at the outcomes in terms of their quality of life and their functional trajectories. And we mapped these out. And what I'm going to show you are going to look like sort of blurry scatter plots, but I want you to kind of bear with me as we walk through this. Oh, first, just as the sample characteristics, there's a lot here. The populations actually look somewhat different because of where they were drawn from, and the diseases themselves have different demographics. What I will say, though, is that all the findings I'm going to talk about sort of were corrected for these differences. Quickly, looking at self-rated health by bed days, what you see is that these are the patients with poor health and high numbers of bed days, which is worse. Poor health, who consider themselves poor health, lower bed days. This is good health, but high bed days. poor health with low bed days. And the bottom line here is that if you look across this, and I know I'm going through quickly, what you will see is that patients with COPD and CHF have much worse self-rated health than the patients do with cancer. They feel worse, they have bigger symptom burdens, they are at greater need of palliative care. Now, these are the scatter plots I'm going to show you. What you're looking at here, these are actually just the patients that died in the study. It's about 108 patients. And each of these lines is a patient. And these are sort of complicated trajectory analyses. But what we did was we figured out sort of mean lines. And I know that it looks like there's such spectacular noise here. It doesn't really mean anything. But in fact, it does. And what we did was we did mean lines for each of the diseases, for cancer, for COPD, and for CHF, looking at the patient's results on the FACT-G for each of the subscales, functional well-being, social well-being, and so forth. I'll walk you through several of these different plots. What you need to know looking at this is that the lower you are, the worse off you are, and the higher you are, the better off you are. So you're feeling better, doing better if your number is higher, you're doing worse if your number is lower, and this just follows a trajectory over time. We cut off at 45 days before death because we generally didn't get an interview much closer than that. And remember, and hospice kicks in right over here at 100, in theory at least. 6-month survival, although in fact we know that the reality is hospice kicks in after these 45 days, right? Because the median survival in hospice is about 3 weeks. So anyway, if you look at functional well-being, they all sort of they track fairly similarly. The cancer patients stay more functional and then dip off more dramatically, which we would have expected based on the curves I showed you before. These, by the way, I'm just going to intersperse with some photos of patients from the study. They gave us the permission to take these photos and to use them in settings like this, because I just want to put a face to what are just a bunch of squiggly lines on the screen. And we enrolled, by the way, the patients and their caregivers. So this is their physical well-being. Now here, as opposed to functional, you see that drops off even more dramatically for the cancer patients. Why is this? This is because of exactly what we talked about before. A week before the death, the CHF patient may not know they're about to die. A week before the death, the cancer patient usually does know. This is a very sweet photo. Now, social well-being. Here you can see that the CHF patients are a little bit lower, the cancer patients are a little bit higher. And here's another family. And then the emotional well-being, again, they're pretty similar. Maybe the cancer patients tack off a little bit at the end there. And spiritual well-being, and I'm not sure what to make of this, but there's this big downward trend. There aren't quite as many patients here. There's big downward trend in the CHF patients. So the bottom line of all of this is to make the point that diagnosis matters. It clearly matters from the point of view of taking care of this patient in front of you and how you're going to treat them, what kinds of interventions and medications you're going to use. But really the bottom line is sick is sick. And these patients are all sick, and we need to recognize that and to have any sense that cancer patients are in a different place this way than organ failure patients. If anything, they're less sick. If anything, they're less sick. Okay, so this is a famous curve that many of you have seen. This is the study by Jennifer Temmel and colleagues at Mass General that showed that early palliative care is effective in lung cancer and shows not only was it effective in many ways in terms of quality of life, but actually had a survival benefit. And so this influenced a lot of us in palliative care and helped integrate palliative care into a lot of our health systems and get systems to invest. But we looked at this and we said, this was lung cancer. This was your classic solid tumor trajectory disease, okay? What would happen in heart failure? Does it work? Can we do the same thing and will it make a difference? I've already shown you how radically different heart failure is in so many ways. So first of all, before we started our study, we looked around, and there is very little out there. But there was a study of 20 patients at Cedars-Sinai with heart failure and palliative care consults, And what they found, and this was very subjective, was that all had moderate to significant impact according to an independent cardiologist and palliative care assessment. So they had people look at the records and see what happened, what they felt had happened with that intervention. What they found was there was a decrease in morphine use, which is actually interesting in heart failure. Our thought was that we're actually going to be using more morphine in heart failure as a result of PC intervention, so this was interesting. But most importantly, they had improved patient satisfaction. They also started initiating palliative care consults in all the patients at the Mayo Clinic who were receiving destination ventricular assist device therapy, and found that 68% of those patients completed advanced directives, and they felt that post-op care was more clear. So what limits using palliative care in heart failure? There are a number of issues. One is determination of prognosis. It's just a lot harder to prognosticate. One is the timing of the implementation. Compared with cancer, it's not even always clear when someone's been diagnosed with heart failure. Turns out many patients don't know they have heart failure. It's an untested intervention in a field that's extremely RCT driven. So to convince the cardiologist that we should do this, they like to see RCTs for everything. So we felt we needed to get there. And there's a lack of training of cardiovascular specialists in palliative care. So we've designed a study called Palliative. And this is a randomized controlled trial of an interdisciplinary palliative care intervention plus usual care versus usual care alone at Duke University. And our primary outcome is quality of life at 6 months, measured on 2 measures, the Kansas City Cardiomyopathy Questionnaire and the FACIT-PAL, which is a palliative care measure. And our secondary aims are all the ones that you see here: patient-reported depression, anxiety, spiritual well-being, resource utilization, and so forth. We have 200 patients being enrolled in this study, and they're being randomly assigned 1-to-1 to the 2 interventions. This study is, by the way, funded by the NIH. And the inclusion criteria are hospitalized for decompensated failure and an escape score, risk score, which is greater than 4. I'll show you that in a moment. And then we have some exclusion criteria, and I'll get to that in a moment. These are the inclusion criteria here on the left. All the sorts of things you might expect. We were trying to get people who are pretty sick. And the escape score, this is something that had been validated at Duke in the cardiology program. And basically a score of greater than, you get points for all of these, and if you have more than 4 points, you're pretty sick and you have a fairly high mortality rate. We excluded patients in the study who were likely to get transplants or VADs because the cardiologist wouldn't play with us if we didn't do that. And we can talk about that at the discussion time. That was a huge issue in trying to set up this study. Our intervention is a physician, nurse practitioner, and chaplain interdisciplinary team. We have protocolized the management and assessment of all of these things. We're using something called the Outlook intervention, which is designed by my colleague Karen Steinhauser to sort of help patients achieve some of their psychosocial needs. And we have structured advanced care planning. One of the things we wanted to do was to get past some of the problems with the TEML study was to say exactly what it is that we're doing, and so we are charting it out very, very specifically. What are the key elements of palliative care and heart failure? These are them. For lack of time, I'm not going to get into it too much, but communication, prognostication, applying models, helping patients understand what to expect, heart failure, specific advanced care planning, symptom management looks very, very different in these patients. Turns out heart failure causes bone pain and causes bone loss, which therefore bisphosphonates are a good thing. Turns out bisphosphonates exacerbate heart failure. What do you do? These are all kind of issues. And then there are all these issues about medical therapy discontinuation. So this study we've just started enrolling. I think we've enrolled our 8th or 10th patient in the protocol. And I will just throw this out there and say this is a study we would love to actually do other places. We have this whole protocol. We would love to do it here in Singapore maybe someday. And so in summary, what I'd like to say is that palliative care has historically been more available for patients living with malignancy than those suffering from non-cancer chronic illnesses. The burden of suffering is similar between these disease groups. In fact, it's probably even worse for those with organ failure. There are unique clinical challenges that exist that required a focused expertise when we're dealing with this patient population. And finally, early palliative care has proven beneficial in cancer. What we need are ongoing trials. We're doing one. There's one other one going on in Colorado, hopefully to see more. Seek to extend this to heart failure. Thank you very much.